Hello everyone and welcome to this discussion on the physiology of hemostasis. In this video, we are going to be having a brief overview of how the body prevents blood loss following injury or surgery, how this process is halted when it has accomplished its purpose, and lastly, we will talk about the abnormalities that may be encountered during hemostasis. Hemostasis is a complex mechanism that prevents or terminates blood loss from a disrupted intravascular space, provides a fibrin network for tissue repair, and ultimately removes the fibrin when it is no longer needed. It is achieved through 4 interconnected mechanisms. That is, a vasoconstriction, platelet plug formation, coagulation or fibrin formation, and fibrinolysis. Vasoconstriction and platelet plug formation are collectively referred to as primary hemostasis, which is the initial immediate response to vascular injury, while the coagulation process is referred to as the secondary hemostasis. Note that these mechanisms are interrelated and occur as a continuum. Now, let's begin with the first mechanism, that is vasoconstriction. When there is disruption in the integrity of the vascular wall, the fastest way that the body responds to stop or reduce bleeding is vasoconstriction. This is what happens. There is a disruption of the vessel wall, then the vessel constricts in order to seal off that disruption to prevent or reduce bleeding. This process is aided by sympathetic reflex and release of vasoconstrictors from platelets, including thromboxane 8-2, serotonin, and catecholamines. The next component of hemostasis is platelet plug formation. When a blood vessel wall is injured, collagen and von Willebrand factor are exposed in the vessel wall, leading to platelets adhesion to these molecules via platelet receptors. That is, the platelets adhere to the collagen and von Willebrand factor in the wall of the vessel via platelet receptors, leading to platelet activation. Activated platelets release the contents of their granules, including adenosine diphosphate, and also secrete thromboxane 8-2, which activate nearby platelets to produce further accumulation of more platelets, which is known as platelet aggregation. This leads to formation of a platelet plug. The next component of hemostasis is blood coagulation or fibrin formation. This occurs via 2 pathways, the intrinsic and the extrinsic pathways, which are aided by the clotting factors. Now, this is the list of all the clotting factors displayed on the screen. We're going to demonstrate how each of these factors play their roles in the coagulation process. Now, let's begin with the intrinsic pathway. The intrinsic pathway is activated when blood is exposed to collagen fibers underlying the vascular endothelium. This activates factor 12. Active factor 12, in turn, activates factor 11. Active factor 11, in turn, activates factor 9. active factor 9 in the presence of factor 8, calcium ions, and von Willebrand factor from platelets activates factor 10. Now, activation of factor 10 is the beginning of the common pathway, which proceeds as follows. Active factor 10 in the presence of calcium ions, factor 5, and platelets cause the activation of factor 2, that is, conversion of prothrombin to thrombin. Thrombin plays two major roles in the coagulation process. First, it converts fibrinogen, that is factor 1, to fibrin. It also causes the activation of fibrin stabilizing factor. Activated fibrin stabilizing factor stabilizes fibrin, leading to formation of a stable polymer that forms a fibrin mesh. Next, let's look at the extrinsic pathway. The extrinsic pathway is triggered by the release of tissue factor, also known as tissue thromboplastin, from damaged tissue external to the blood. It is called extrinsic pathway because it is initiated outside the blood. Tissue factor activates factor 7, and together these two factors activate factor 10. This is another way in which the common pathway is kick-started. Now, let's review a quick and simple way in which we can remember the clotting factors for the intrinsic, extrinsic, and the common pathways. For the intrinsic pathway, we count downwards from 12 to 8, skipping 10. That is 12, 11, 9, 8. These are the clotting factors responsible for the intrinsic pathway. For the extrinsic pathway, we can remember the clotting factors by virtue of the fact that 7 plus 3 equals 10. That is, the clotting factors for the extrinsic pathway are 7 and 3. To remember the clotting factors in the common pathway, we use this memory trick. 5 times 2 times 1 equals 10. That is, the factors in the common pathway are 1, 2, 5, and 10. The next component of hemostasis is fibrinolysis. This refers to the breakdown of the fibrin clot, which allows restoration of blood flow during the healing process following injury or surgery. This process begins at the same time that clot formation is initiated. Fibrin polymers are degraded by plasmin and also by phagocytic cells of the reticuloendothelial system. This process releases fibrinogen and D-dimer into the system. Additionally, further clotting is prevented by the following. First, thrombin action is limited by the following processes. Thrombin is absorbed by the fibrin clot, thereby reducing its availability. Also, antithrombin 3 combines with thrombin to form an inactive complex. Also, fibrin degradation products also inhibit thrombin. Another mechanism through which further blood coagulation is prevented is through the tissue factor pathway inhibitors. That is, products of endothelial cells inactivate tissue factor 2 complex. Another mechanism through which further coagulation is prevented is through the protein C anticoagulant pathway, which inhibits factor 5 and factor 8. Protein C acts as cofactor in this process. Now, a brief look at abnormal hemostasis, which may lead to excessive bleeding during and or after an operation. Abnormalities may be due to platelet abnormality. Platelet abnormalities may be quantitative or qualitative. Quantitative platelet abnormality include thrombocytopenia, that is, platelet count less than 150 times 10 raised to the power 9 per liter. It could also be qualitative, including Glanzmann disease and Bernard-Soulier syndrome. Generally, excessive bleeding occurs when platelet count is less than 50 times 10 raised to the power 9 per liter, while spontaneous bleeding occurs when platelet count is less than 20 times 10 raised to the power 9 per liter. Another cause of abnormal hemostasis is deficiency of clotting factors, which could be hereditary or acquired. Hereditary deficiency of clotting factors include hemophilia A, von Willebrand disease, hemophilia B, also known as Christmas disease. Acquired deficiencies include vitamin K deficiency, uremia, massive blood transfusion, as well as diffuse intravascular coagulation. Anticoagulants can also cause abnormalities in hemostasis. Examples include warfarin, which interferes with hepatic synthesis of vitamin K-dependent clotting factors, that is, factors 2, 7, 9, and 10, as well as protein C and S. Heparin also affects blood coagulation. Low-dose heparin inactivates active factor 10 and also inhibits the conversion of prothrombin to thrombin, while high-dose heparin inactivates factors 9, 10, 11, 12, and thrombin, and also inhibits conversion of fibrinogen to fibrin. Other causes of abnormal hemostasis could be due to vascular problems. Vascular problems could be congenital or acquired. Congenital vascular problems include hereditary hemorrhagic telangiectasia, Ehlers-Danlos syndrome. Acquired vascular problems include drugs like steroids, also sepsis, trauma, vasculitis, infections, scurvy, and purpura.